First of all, I would like to thank the AIOC for giving me the opportunity to have this IC. This is a comprehensive IC for ocular trauma of intermediate level. So, as we all know that ocular trauma is quite common, and we encounter a variety of cases every day in our practice. And the idea behind having this IC was to give a comprehensive overview about how do we manage from the simplest of trauma like a foreign body on the cornea to the most complex of the open globe injuries that may come to us. So I'm Dr.VANASHREE NAIR. I'm a consultant at Giridhara Institute, Cochin. And I would like to talk today upon approach to the patient of trauma. So when a patient comes with trauma, it is not only the eye that is affected or the body that is affected, but the person is psychologically traumatized. And first of all, what we need to do is to calm the patients, calm the relatives, check the general health, the GCS status, what is the systemic trauma, is the patient systemically stable or not. First, we need to address that. And once we know that the patient is systemically stable, we can address the eye trauma. So the history of injury is very important. Few points that I would like to highlight in my talk is the history of the injury, first aid that we can give to the patient, prognostication, how grave is the situation, documenting all the data, and the medical legal aspects involved in ocular trauma. So as we all know that history is the most important part of any ocular disease, and trauma is no less. Rather, it forms the most important part because that's where we know what has exactly happened, when it has happened, were there any witnesses, how much time has lapsed from the injury, what was the mechanism of injury, and is there any associated head injury, because that is very common along with ocular trauma. So the symptoms that the patient might come with, as we all know, it might be drop in the visual acuity, it may be just floaters or flashes, there may be pain, or there may be diplopia. We need to know the systemic diseases that the patient has been suffering from, the tetanus status, the drug histories. The patient, many times in a hurry, we may forget to ask, is the patient taking any systemic medications, any blood thinners, is there presence of any allergy? So in a very acute setting, say like a chemical injury, we may not take a detailed history, but when the patient is slightly stable and we can elicit history while giving the first aid, it is better that we remember the flow of line, how do we go about taking the history so that we do not miss anything important. So coming to examination, a few of the things that I would like to highlight on is in visual function, we need to take the visual acuity of both the eyes, at least the distance visual acuity, and whenever possible, even the near visual acuity. Check for RAPD, color vision, and a gross confrontation at least to see if there is any field effects. For the orbits, need to see the continuity of the rim, if the infraorbital sensation is reduced, or if there any crepitus is felt. Soft tissues, if there's bruising, edema, emphysema, or any lacerations that are seen. The globe per se, there may be proptosis, there may be enophthalmos, hypoglobus, or we can even check the pulsatility if there is any carotid cavernous fistula that is suspected. Motility of the eyes, if there is any mechanical restrictions, the muscles may be entrapped. The conjunctiva sometimes may have a large subconjunctival hemorrhage, and that may be hiding a laceration behind, or in case of a chemical injury, may have ischemia. Cornea, it is very easy to see if there is any superficial abrasion, any laceration, foreign body, rust, infiltrate. This is just an enumeration of all the things that might probably be there, but we need to keep in mind to check everything in details. The AC may have, first you need to see the depth of the AC. In cases of blunt trauma, you may have angle recession, so we need to see that. There may be flare cells or pigments because of the pigment dispersion because of a traumatic iritis. If the patient is stable and it is a closed globe, then when warranted, we may need to do gonioscopy at a later stage. See the iris for any anisocoria or a traumatic mydriasis, there may be sphincter tears. The lens may develop cataract, there may be phacodonosis, subluxation, or there may be a foreign body sitting there. Intraocular pressure, sometimes the globe may be very soft, then you can suspect that there might be a penetrating injury, or maybe patient has undergone retinal detachment. The vitreous, again, there may be hemorrhage, pigments, posterior vitreous detachment might have occurred. Retina can have edema, hemorrhage, tear, peripheral detachment, a dialysis may be there. So whenever it is possible, we may have to examine the retina in details. And when we suspect any fracture or intraocular foreign body, then CT orbit is required, and we need to give the specifications to the radiologist as to what are we suspecting, and maybe we may require a 2 millimeters cuts to find out a very small foreign body. So coming to the classification. This is a very simple classification. That's the BETS classification. It is an age-old classification. So, but it is very important to classify to know the extent of trauma or damage that is there to the eye. So very grossly, it has been divided into open globe injury or closed globe injury. When we say closed globe injury, basically we mean there may be a contusion or there may be a lamellar laceration. So the globe structures have not yet opened up. In an open globe injury, there may be a rupture of the whole globe or there may be a laceration. Again, with the laceration, you may have intraocular foreign body. There may be a perforating wound where there's where there's only an entry, and a perforation where there's an entry and exit, and a penetration is where there's only an entry and a foreign body may be sitting inside. But this classification did not include the periocular structures. So it was modified, and there's a modified BETS classification which also involves the periocular injury description. For the residents and for even for all of us, it is important to know the zones of injury so that the description of the injury is very clear cut and we know what we are dealing with. So when it comes to open globe injury, the zone 1, 2 and 3. Zone 1, we know that it is the cornea and the limbus. From zone 2 is limbus to 5 millimeters posterior into the sclera, and zone 3 will be posterior to 5 millimeters from the limbus. And in closed globe injuries, it is the zone 1 is the external anterior segment, conjunctiva, sclera and cornea. Zone 2 will be the internal anterior segment, including the lens, zonules and the pars plicata. And zone 3 is the posterior segment, where the vitreous, retina, optic nerve, choroid and the ciliary body are involved. Now the prognosis, we need to prognosticate the case, because we can ourselves predict what can happen in the future, what will be the visual outcome, and we can even counsel the patient and give them an idea as to what can be expected in the future. So that was based on the ocular trauma score, and not going too much into the details of the score, but further studies are going on. That is the IGATES, which is a registry. It is an international globe and adnexa trauma epidemiological eye study, where 18 participating centers from 8 countries are bringing together data on trauma, where we have an online platform which is used to enter all the data, and this data is being used to see how, so there was an IGATE study 1 and now the IGATE study 2 is going on to create a new prognosticating scale to know how the patients will do in future. So coming to surface injuries, I'm going to describe a few of the surface injuries that we very commonly deal with. So in surface injuries, most commonly what we have is blunt injuries or chemical splash, abrasions or partial thickness injuries. Sometimes we have an insect fall, sometimes there may be some toxic chemical plant exposure, or even a small stone might be there. So epithelial defect is one of the most common injuries that we encounter very routinely in OPD. Now, most commonly what we see is, fingernail or sharp paper edge or any sharp pointed object that might just come and scrape the epithelium. Sometimes it is difficult to find out that there is an epithelial defect. So whenever the patient comes with the foreign body sensation, it is always better that you stain the cornea to see at what point that you may find an abrasion. The abrasion sometimes may not be even on the cornea. Even the conjunctiva may have been just abraded because of some foreign body which has gone away. Or you may even find a hidden foreign body, a translucent foreign body. So there is a chance of microbial keratitis that we need to take care of. I think it is important that we instruct the patient that don't go and wash their eye, because they have a foreign body sensation. Patients go and they'll wash their eye with tap water or any other water source, which itself might lead to a microbial keratitis. And a sharp paper edge or a fingernail injury can predispose the patient to recurrent erosions. So that is something which we need to look out for. We need to tell the patient that after a few months you may land up with a recurrent corneal erosion, and that may need proper treatment. So in the primary epithelial defect, lubricants, antibiotics, cycloplegic drops sometimes if the patient is very symptomatic with pain. And nowadays patching is not considered to be good because it delays healing. So it's better to avoid patching, rather maintain the patient on lubricant drops per se. Now, I already spoke about RCS, so it is important that we identify that this is not a fresh epithelial defect, but something which is like a recurrent corneal erosion. So the patients will come with a typical history that in the early in the morning I get this watering or irritation in the eye, and then during the day it settles off, or sometimes in 2 to 3 days it settles off, and they'll have this recurrence every 2 to 3 months. So they need to be counseled that this has happened because of one prior trauma that the eye suffered, and this needs to be identified and treated properly so that the incidence can be reduced. And the line of treatment for it is sometimes we give lubricants. They may need NaCl drops, and in rare cases you may need even a bandage contact lens for some time. And lifestyle modifications, yes. So another not very common, rare it is, but it happens that sometimes you have this caterpillar hair injury. You know, patients are exposed to these insects while working in farm or garden or while they're traveling, and they have these very sharp needle-like caterpillar hair which go and deposit on the cornea or in the conjunctiva also, and sometimes it becomes very difficult to identify them, but the patient keeps coming back with a foreign body sensation. So it is very important that you patiently try and hold onto the the outermost tip of the caterpillar hair and try to nudge it out and pull it out with a sharp Macpherson's forceps. Sometimes they go very deep. If they go deep into the stroma, don't go behind them, because you're going to go and cause more and more injury to the cornea. We wait and we'll allow the body to heal. In that process, sometimes the caterpillar hair may be extruded out. Even in the superior tarsal forceps or the inferior tarsal, sometimes you have this very fine caterpillar hair which need to be patiently removed by and by. And a close follow-up we can do, and after a few weeks also, sometimes you may still find 1 or 2 caterpillar hairs which can be removed later on. So coming to chemical injury, the most important point to remember in chemical injury is don't ask any questions. No vision, no history. What was the chemical injury with? Whether an alkali or an acidic, if the patient can give you the history. But first, foremost, eye wash. Ask the patient if they have given any eye wash anywhere, like, sometimes they are referred. So they might have already given an eye wash, but it is always a good idea to repeat the eye wash, at least with 2 liters of fluid, so that we know that most of the conjunctival sac and cornea is free of the chemical that might have gone. And most of the times it is the domestic agents like a mild alkali agent which might have caused the chemical injury. So we know that alkali, they have a liquefactive necrosis, so they go deeper into the tissues and cause more damage. Acids, a small acid, they have got a coagulative necrosis property, so they usually tend to remain more superficial. So these are some of the common, chemical substances which might cause chemical injury, and it's a good idea to know which of them might be acidic or alkaline. And anyways, you can use the pH strip test to what is the time? Okay. So pH strip to know the pH of the status, and then accordingly you can treat further. So the treatment, as we all know, that test the pH, give topical anesthesia, irrigate, copiously irrigate, inspect the phonesis, and if the pH is neutral, recheck after 20 minutes and repeat the irrigation if required. And this is the classification. I'm not going into the details now, but it is important to remember that is Roper-Hall classification, which was the older classification, and the Duas classification is the new classification, which gives a better prognosticating picture regarding this. These are some of the pictures that I have shared. So what all can happen is, the complications is you can have conjunctival burns, significant limbal ischemia. We need to refer the patient to a corneal expert who can manage further if there's a large ischemia noted. And for the further, this is a case of the grade 6 chemical injury that had come. And the foreign bodies, again, I had already touched upon that. And blunt trauma is just one thing that I would like to add. That very commonly we have this shuttlecock injuries, or which are like a closed globe injury with the coup and counter coup effect. And what you can have is iritis, hyphema, sphincter tears, Berlin's edema. We need to follow these patients closely and get all the checks done. So this is one of the cases which suffered from blunt trauma. As you can see, there's hyphema here, and the post 2 months later, the sequelae that remained was an anisocoria in the left eye because of the sphincter damage that had happened. So the take-home points are that this is a very seemingly commonly encountered problem. So trivial injury may be sometimes be hiding something big inside. Vigilance, counseling, and primary care very important. And timely and appropriate management will reduce the ocular and visual morbidity. Thank you. Next. Ma'am, can you please, next I would like to invite Dr. Marian Pauli, ma'am. She will be talking on 10 tips on management of the ocular lid and adnexal surface trauma.
Good morning. Good morning, everybody. At the outset, let me thank Dr. Vanashree for giving me this opportunity. We know trauma is very, very important. So my topic is 10 top 10 pearls in management of lid and adnexal trauma. So first pearl, Dr. Vanashree has already discussed. But one point which I would like to add is like if you're suspecting orbital injury or lid injury, always make sure there is no CNS injuries. There are instances while we are doing lid tear repair, patient develops seizures. So loss of consciousness, bleeding from the nose. This history has to be asked before you take up the patient, especially if you're working in a single specialty hospital. Multi-speciality, it is okay. Coming to the second pearl, so when you see a lid tear patient or any adnexal injury, suspected adnexal injury patient, always inspect the wound, clean the wound, and document the wound. So this is a case which just, if you see from external side, is just a wound involving only the skin or muscle. But when you explore, the patient has got levator injury also. So this is irrigate and explore. That is a dictum: clean, explore, and then document. So that is very, very important in this case. So here also, if you see only this lid margin injury, but if you look very carefully, there is a small abrasion kind of thing near the medial end. When you explore, the patient is having a canalicular injury. So this happens very often, missing trivial injury. When you look at it, looks very small, but when you explore, this is a big injury. So after exploring, do not excise or discard any tissue and look for a presence of orbital fat. If there is orbital fat in the wound, that means the septum has been injured. So again, you explore to see any further levator injury or not. Then infraorbital as well as supraorbital anesthesia that shows there is a fracture. Then TT and all she has already mentioned. So coming to the pearl number 3, anesthesia. So we know litter is not an emergency. So anesthesia can be either local anesthesia, general anesthesia. Preferably local anesthesia include adrenaline also because it gives you hemostasis, or local anesthesia with the monitored anesthetic care. That is, you can give some sedation. That depends on the hospital which you are working and the pediatric or adult. So pearl number 4, coming to surgical principles, reapproximate the tissues as accurately as possible. Then close with minimal tension. If you put the wound under tension, it can gape. Then obliteration of the dead space. Don't just put 1 or 2 sutures and close. You have to do a layered, layered closure. Then good lighting and hemostasis finally. So I'll come to a few clinical scenarios. The one is superficial or deep laceration, but the margin is not involved. So in this simple closure or layered closure, you can use 6-0 vicryl for the orbicularis and 6-0 silk, nylon, or plain gut for the skin. We prefer interrupted sutures. Running all sutures also can be done, but the problem is if there is a collection, you can get a hematoma. So if you are putting running sutures, give nice ice compresses so that oozing will not come, and try to get an everted skin edges so that you will get a very good scar. Should never close the septum. So I'll just tell you how to identify a septum in my later videos. Then undermine the edges if you think there is a minimal tension to the wound, and suture removal can be done in 5 to 7 days if you're using an non-absorbable sutures. Then the coming to the role of glue. If it's a very small dry wound, you can use cyanoacrylate glue. The thing is, if you're putting cyanoacrylate glue, preferably don't put antibiotic ointment because ointment can aggravate easy. It will facilitate the easy disintegration of the glue and the wound can heal. So but it should not be used in ragged wound, contaminated and crushed wounds. It is only for a dry, clean wound with no ooze. Then the role of taping. This is also again superficial, only skin deep. You can put a steri strip. You can put the steri strip so that the scar is going to be very good. Coming to the sixth pearl, that is lid margin tears. So triple suture technique, that is, one is meibomian gland orifice, 2 is gray line, and 3rd is lash line. So there are some important things: knots tied in the end anteriorly and long end of sutures anchored to the skin. I'll just go to the video. So local anesthesia is infiltrated. Then identify the meibomian gland orifice. Take sutures through that. This is a little very fast video. Wait. Then tarsus is sutured with vicryl. Then again go to the lid margin and suture the lash line with a non-absorbable IU60 Then you finalize the orbicularis can be sutured with the vicryl and skin is also closed. And finally, the wound is secured in the anterior part so that the sutures will not rub the cornea. So in pediatrics, you can use 50 vicryl. So these are the few cases where lid margin is sutured, and if you do a good suture, you will get a very good result. The main problem is if your alignment is not correct, you can get trichiasis that can create troubles later. Coming to the levator injury, it is suspected when there is fat in the wound or when the patient presents with ptosis. So in this left eye, he has got a ptosis, but when you look from the external side, there is no wound. But when you, in this case, you should evert the wound and evert the lid and see. So he had a levator injury, but it improved by itself. So now, how will you identify the levator in a wound? So once you see a suspected levator, grasp that structure and ask the patient to look up and down. So the levator will move along with the up and down movement, whereas septum will not move. And when you grasp the septum, there you will feel a tension. That is, the septum is attached to the orbital rim, whereas the levator goes back to the orbit. So levator will move along with up and down movement, septum will not move. So this is the key point in how to identify the levator. It is repaired using 60 vicryl, and the levator is totally detached. You have to reattach to the tarsus again with either you can use vicryl or 60 proline, but before using proline, make sure it is levator, otherwise it can create other troubles. And septum should not get incorporated into the wound. So this is again another case. That's 29-year-old male had a fall from height, lid got hanged in the iron rod. So obviously when you look, the patient is not opening the lid. That is, there is a complete ptosis with a ragged lid wound. So don't consider this ptosis is due to mechanical edema. He had a total LPS avulsion. So when we explored, he had LPS avulsion as well as he had a lateral rectus injury also. So identifying levator injury is very, very important. It has got medical legal implications also. So this is his postoperative day 1, again total ptosis. At 3 months, he had residual ptosis, which improved 6 months, and later he underwent levator resection. So in traumatic ptosis, you will wait at least 6 months to 1 year before you correct the ptosis. Coming to the Pearl 8, that is total lid avulsion. So this is a case presented with a total lid avulsion following injury with the bicycle. So when the patient presents like this, if you can retrieve the lost tissue, it is always well and good. And ask the patient to keep the retrieved tissue in a gauze and soaked in gentamicin, and later it can be reconstructed. Reconstruction at the earliest is the most important thing, but most of the time 6 hours also it gives you good result because lid is a very forgiving structure. Coming to Pearl 9, coming to the adnexal injuries, one is eyebrow. It can occur either in isolation or in continuation with the lid. The skin is thick. So always do 2-layer closure is a must. Deep closure should result in skin approximation. You can use 4O or 5O vicryl where it interrupted. Coming to the adnexal injuries, that is canaliculus. So in canalicular injury, the main challenge is to identify the distal end of the canaliculus. So I usually identify the distal end under microscope itself, even though various other methods like using fluorescein, using methylene blue has been described. So just look, this is the microscopy picture. So in this muscles, you can see it is more red, more pink, whereas mucosa is a uniform line structure. So in this structure is the canaliculus in this, and this is usually just underneath the conjunctiva. So coming to the video. So first dilate the punctum with the punctum dilator. Then I use mini Monaco stent is inserted. So once the distal end is identified, your job is almost done. You can do syringing to confirm whether the patency and whether you are on the correct path. Then the tube is inserted, that is minimum stent. Then the peritubal structures, you can put anteriorly and posteriorly structures closed with the 7O vicryl, and the skin is closed in the routine fashion. Now coming to canthal tendon injuries, that is medial canthal tendon and the lateral canthal tendon. This is very, very important. If you don't close the tendon, you can get either ectropion or lid retraction. Patient might not be happy. If only the superficial laceration, you can just directly close. This is very important, especially in canalicular injury. You can get an associated medial canthal tendon injury. So, if the posterior limb of the medial canthal tendon is injured, you have to reattach to the periosteum. You can use 4-0 vicryl, or you can use proline also. The problem with the proline is the knot should be buried, otherwise it can get extruded later. Post-op care, can patch for 1 day or 6 hours, start systemic and topical antibiotics, ice compresses, do a little bit of head elevation so that edema will be less, and scar massage after suture removal. If it is parallel to the lid crease, then it is okay. Scar might not be a problem, but if it is vertical to the lid crease, do a scar massage. And there are some various anti-scar creams are also available if the patient is very much concerned about the scar. Most of the time, the scar will settle without any specific scar treatment. Coming to the final pearl number 10, that is management of sequelae. If you do a very good lid tear repair, sequelae are very minimal, but there are some sequelae which is inevitable. So you can get notching, then lag of thalmos, ectropion, entropion, canalicular block, and canthal malpositions. So that all, this is 1-2 months post RTA. She had an extensive skin loss. So she had an ectropion, which we have corrected later with a full thickness skin graft, because this ectropion was not settling even with anti-scar treatment. So waited for 6 months, and then we did ectropion correction. Similarly, this is lag of thalmos with the corneal ulcer due to the anterior lamellar deficiency and the lid notch. So in this case, we can't wait because there is a functional deficit in this. So the moment patient presented to us like this, we corrected the lag of thalmos with the anterior lamellar. Anterior lamella is strengthened with, augmented with skin graft, and the lag of thalmos has improved. So these are my top 10 pearls. So excellent functional and cosmetic results are possible with planned and meticulous surgical technique. Thank you.
Thank you so much, ma'am. That was a wonderful 10 points that we could take. Ma'am, please come on dais. Dr. Marin Pauli, ma'am, is Senior Oculoplasty Consultant at Giridhara Institute. And thank you so much, ma'am. Yes, ma'am. Next, I invite Dr. Sugaranjini. She'll be speaking on corneoscleral injuries, principles of suturing, and management tips.
Any doubts regarding, meanwhile she prepares for the talk?
Any doubts, any questions from the audience? Ma'am, I would like to ask, as a comprehensive ophthalmologist, if we encounter lid injuries and simple lid injuries, should they be attempted to repair, or is it a wise idea to send to an oculoplasty?
No, all lid tears can be managed by all ophthalmologists, because it does. I mean, it is just an anatomy and approximation of the anatomy what we see. And if there is make sure there is no tissue loss. If there is tissue loss, then either you can do you can do the primary repair, and later reconstruction can be done later. If there is no functional deficits, like for example, gross lag of thalmos, etc. Otherwise, everybody can do all the lid tears, no problem.
And ma'am, one more question. If there is a small laceration, say around 2 millimeters, 3 millimeters, or when should we go for a steri strips, or suturing is a must?
Steri strip when there is no bleed and it is clean wound, like injury with a knife. Like most of the time, kids will come with a small injury with the kitchen instruments. So small wound, just put the tape, it will settle. If no bleed, the steri strip will stay back. If there is bleed, it will not.
Thank you, ma'am.
At the outset, I would like to thank Dr. Vanashree for bringing us all together and giving me this opportunity to present on principles of corneoscleral injuries. So, not only to me, to everybody, trauma, a open globe is always a challenge, and it
Slides
can
on
be.
the screen, please. Slides.
Yeah. So, as I was saying, an open globe is always a challenge, and it can be pretty much compared to a war field where nothing is under your control and you need to bring it back into your control. So, for me, the four rules of corneoscleral repair is that one is that your hand can only do what your mind knows, and you need to choose your right weapon. And once you have chosen your right weapon, you need to strike it right. And once you have planned how you're going to strike the wound, you must go into attack mode. So, what do I mean by hand can only do what the mind knows? While examining a patient of corneoscleral tear, your planning must start right at slit lamp examination. So, when you're examining the patient, these are the things that you must note before you even enter the OT. That is the depth of the wound, whether it is a full thickness wound or whether it is a lamellar wound. A full thickness wound, the points in favor of this is that accedals will be positive, the anterior chamber will be shallow, and sometimes the intraocular content will be very much hanging out. So you know that you're dealing with a full thickness wound. But whereas in a lamellar wound, accedals test would be negative, and the patient might be still having some considerable vision, and none of the intraocular structures will be falling out. So you know that you're dealing with a lamellar wound. Next, you must determine what is the pattern of the wound. So, what do I mean by pattern is that whether the corneal tear is a linear wound or a shelved wound. So, as you can see from the picture on top, a linear wound would definitely be gaping, but whereas a shelved wound would be self sealing and may not require a suturing itself. You could just place a bandage contact lens for such patients and they will heal really well underneath it. Whereas an open linear wound will definitely need suturing. You must also keep in mind what the timing of the injury, how much time has lapsed between the injury and presentation. If it is a fresh wound, you would expect lesser contamination or infections. But if it is older than 24 hours, it would be ideal to send for scraping for microbiology as well when you're planning for the repair. And also, if you have any tissue prolapse out of the wound, like the iris, then if it is again, if it's a fresh wound which is less than 24 hours, you could reposit it back into the eye before suturing the cornea. Otherwise, if it's older than 24 hours, you could resect it off because you do not want to reposit it back and increase your chance of infection. If there is any foreign body, you have to explore, you have to note the foreign body in the slit lamp examination as well. But this could be quite challenging when the patient is very young. If it's a child and not cooperative or in too much pain, then you might have to go fishing for the foreign body once you have induced general anesthesia. But if you have noted a foreign body on slit lamp examination as well, you must plan your approach for removal. Like if it is in the anterior chamber, you must plan where you're going to put your incision to remove the foreign body based on the size of the foreign body and what your approach is going to be. And also, you must examine the patient for other associated injuries. A scleral injury might be hiding under a chemosis or a subconjunctival hemorrhage, and you must be prepared for it. And if there is any conjunctival or lid laceration, then you can call your oculoplasty friend to repair your lid surgeries. So once you have determined what your injury is, you must choose your weapon. To close a sclera, a 7-0 or an 8-0 vicryl absorbable suture would be ideal. To close a conjunctiva, an 8-0 vicryl would be ideal. If you're dealing with a cornea, you could use a monofilament 10-0 nylon with a fine spatula needle to prevent trauma to the cornea. And if in case you're closing the iris, a 10-0 Prolene would be ideal. If you're dealing with a corneoscleral wound, the first suture must always be at the limbus to approximate the limbus, and then you could repair your sclera starting from anterior to posterior. In many of the cases, you may not be able, you must suture the sclera till you see the posterior end of the scleral tear. So you must resect the conjunctiva to identify the posterior end of your scleral tear. So once you have chosen your weapon, the only thing left to do is to strike it. So how will you introduce the suturing? So the first, I will be demonstrating this in the video as well. The angle of your needle while you are taking the first bite into the cornea should be 90 degree to the surface. So it should be 90° to the surface, and once it has entered through one end, while it comes out through the other end, it also must be at 90°. This is when you get the good curve, and you must also be at 90% depth on either side. Why is this so and you must also be at equidistant on the both sides. Why is this so important is that a compression force elicited by the triangles on either side of the suture are formed once you tie the knot, and these compression forces, the triangles must overlap on each other for you to get a watertight closure. So this you will achieve only if you are equidistant on either side of the wound while entering and while exiting, and also your suture length must be equal to the distance between the two sutures. That is when your compression triangles will overlap and you'll get a watertight wound. So what happens when they don't overlap? So when the compression triangles don't overlap, as in this case, because the distance between the sutures is too large and it is larger than the actual length of the suture, then you can expect a leak and your wound will not oppose. And also you must have already determined whether you are dealing with a linear wound or a shelled wound in your slit lamp examination. And in a linear wound, your point of entry and your point of exit, as shown by the red box, must be equidistant on the anterior surface of your cornea. Whereas when you're dealing with a shelled wound, which will most probably be self-sealing, but if it is not and you're taking it up for suturing, you're as highlighted by the red box below, it has to be equidistant on the posterior aspect. And if you are equidistant on the anterior aspect of the wound, your wound will not seal well. So this is very important that you differentiate whether you're dealing with a linear or a shelled wound. Linear wound, you're equidistant on the anterior surface, whereas in a shelled wound, you're equidistant on the posterior surface. So this is a video where I'm creating a shelled wound myself, as you can see. And I've already created a linear wound on top. This is a practice corneal button. So just to highlight the wound more clearly, I'm going to stain this with Trifan blue. And once it is stained, you can see now when I'm touching with the bud, when I'm touching the linear wound, there is a leak. So linear wounds need suturing definitely, but a shelled wound is not staining the bud, which shows that they can be self-sealing, and you can just put a bandage contact lens and send this patient. But now we are going to go ahead and suture this linear wound. So if you remember our principle, first we need to go 90°. You can see that the needle is 90° to the surface. I'm entering it. To help yourself, you could probably just hold the other end and see if you're entering at 90% depth. I do not do this usually. I do not hold at the wound. I hold elsewhere, and you can just with practice and with time, you will know if you're at 90% depth. And just knowing that the air bubble is not prolapsing out, see, this is a linear wound which is leaking without a suture, so this needs to be sutured. So just with practice, you can observe again that you enter at 90°. Just notice the way I'm holding the needle. It has to be completely curved towards you so that you get a 90° hit at the entry point, and you exit at a point which is equidistant on either side, from the suture. And once you've done that, you just tie it in a traditional way using a 3-knot. Now, the second principle of linear wound, if you remember, is that the distance between the two sutures must be as much as the length of the suture. So I will be showing that next, where I'm taking a suture here. I'm taking a suture here which is almost equivalent to the length of the suture itself. The distance between these two sutures is exactly the same as the length. So once I tie this suture, you can note that this wound will not leak. I'm sorry about this. Okay, I will be just skipping the rest of this video because it's not playing. So moving on to the zigzag, if you might be dealing with a zigzag wound, it is better not to use the thread a needle through the apex of the wound or to prevent trauma to the apex. You could take a suture bite which is a little beyond the apex and then pass it through the two sides and then tie it up ahead of the apex and prevent trauma to the apex of the wound. It will get opposed by itself. Now, coming to a stellate wound, these are the hardest to suture, and you have two different methods in this. In the first one, the Eisner's method, you could create a partial thickness tears or self-induced cuts in between the stellate wounds, and then pass the suture through these bites. And once you oppose all the sides of the apexes will come in the center and meet by themselves. Or you can use the Atkins method where you do not create this partial thickness wound in between, and the idea is to prevent trauma to the apex and make the apex opposed by itself. So this is a video showing the same. Again, I have created the stellate wound, and on staining you can see that there is a stellate wound in the center. And now I will be creating the partial thickness wound in between the stellate points. This is a practice tissue and the blades are not quite sharp, but your trauma patients will be similar to these anyways. I'm creating these partial thickness cuts on the cornea in between the stellate wounds. I've stained the back surface so that it's easily visible. And once you have done that, you just have to start your first suture by passing it through the through the partial thickness, pass it through the two lips. And then the important point is to exit through the second partial thickness wound that you have created. And again, you go back through the same partial thickness wound. And pretty much follow the same path. So these partial thickness wounds are self-healing, and the advantage is you need not remove the suture even, because this suture will be within the depth of the cornea. Again, you pass through the two limbs, come out through the partial thickness third incision that you have made, and then so on ahead. And once you have reached the primary partial thickness wound, you can tie up your suture. And this suture will lie within the substance of the cornea. When I tie the knot, you can see that it will lie within the substance of the cornea. And once you have tightened it, the apexes of the stellate wound will come to oppose by itself. And you need not put a suture on the apex for them to oppose. This is quite difficult to do in real life. So you could probably hope that you don't end up with a stellate wound on the day of your emergency. So as you can see, the suture lies within, and you need not remove it at a later rate. And in case of a necrotic wound, a simple suturing will not help, and you might have to apply a glue or a cyanoacrylate glue over the sutures because there might be persistent leak in spite of suturing. Thank you very much for your patient listening.
Thank you, Dr. Subranjani. Any questions from the audience? No, I think. I have a question for you. I have rather two questions. First is about the Seedles test, just to give an idea to the young students or postgraduates. There's a simple Seedles test and there's a forced Seedles test.
Yeah.
Can you share some of your tips how to go about it?
If you see contents actually prolapsed out of the eye, then you're not going to do it. The only place is probably when you're confused whether it's a lamellar tear or a full thickness tear. A lamellar tear probably which is extending almost to the posterior, you're not so sure. That's when you'll do a Seedles test and check. And if you want to be double sure, you can just give a slight pressure in the outer area of the eye and then see if it is actually. You can also look for the wound gape, and if there is a dilution of the dye, you take the Seedles and you just wet it there, and then you look for the dilution of the dye, like
with the aqueous.
Yeah.
So do you use a bud or something? What do you use to give pressure at probably at the limbus?
No, with a finger is enough. I
With
don't
the
use
finger across the
yeah.
And should the pressure be given where the area of the wound is to try and gape it up, or should be away from? How do you what would you suggest?
You can give it in the, it's safest to give right above or in the side, but it would be, it's not that difficult actually.
Okay, and just one more question.
Yeah.
Sometimes you have a corneal tear, which like in a few of your last slides you were talking about it.
Mm.
It may not be a clear cut wound, or there may be some sort of a necrosis or infection in that
Yeah.
area. So how do you deal with that kind of a tear?
So yeah, the timing is important, and if you're suspecting infection, better to send for corneal scraping also to rule out infection. And if you are dealing with a necrotic wound, along with your suturing, when you're checking, better to make a paracentesis also, and then check if that sutured area is leaking. And if it is leaking, then it is ideal to put a cyanoacrylate glue overlying your suture for a, you're protecting this wound in a double protection rather. So it might have a poorer visual outcome, but that wound will not heal otherwise anyways with just suturing. So
Okay.
a glue would be your good friend that time.
Okay, thank you so much.
Thank you.
Regarding the sedals, if you are looking for a partial thickness, you can press anywhere you want. You can press at the limbus.
Yes. Yeah, we can.
So you can either press at the limbus or anywhere, but if it is a sutured wound and you want to check whether it is leaking, then you should press something anywhere near the wound, because that will give away the valve mechanism. So it should be at the periphery, at the limbus. Only then you will know whether actually the wound is sealed because of your suture. Lamellar you can press anywhere, okay, because even a valved wound should be sutured if it is a full thickness wound.
Thank you, sir. Yes, sir. Yes, sir. Yes, sir.
That is comfortable, or 3 interpretation is comfortable?
It is definitely the surgeon's choice, sir.
Of course. Another my doubt is there a prerequisite of injecting air bubble or visco to maintain the anterior chamber? You are suspecting a collapse of the anterior chamber.
Yes.
So long as the lens and everything is intact.
Yes.
Is it air bubble or viscous? Of course, if you put a viscous, you will struggle with taking out the.
Yeah, removal of viscous is quite a challenge in these cases. So ideally, yes, I do make a paracentesis in all my cases, and air bubble is the first choice. But in some cases, when you cannot avoid it, then you might have to use the visco. A good wash later on should do the trick. Yeah.
Viscous and suturing is a cumbersome procedure.
Yes, yes, yes. Yeah, air bubble is definitely the first choice. Yeah.
Just make a comment. If you make continuous suture, central gaping will not be. Maybe that is the central gaping is then will take out the approximate
First.
that is there. But sometimes if it is tightening is more if you gape more if you give interpretation to the.
Thank you.
Okay, next I invite Dr. Soni George. He'll be speaking on secondary management of traumatic cataracts, some of the tips about biometry and IOL selection as well.
At the outset, let me thank Dr. Vanashree for the opportunity to present in her instruction course in trauma, management of trauma. And I'll be talking about, I'll be talking about biometry, IOL selection, and secondary management in various traumatic cataract situations. See, basically, biometry is a process by which you arrive at the correct intraocular lens power which has to be implanted to make the patient as immetropic as possible. So the various factors are, the effective lens position calculation, the axial length calculation, the measured anterior chamber depth, the keratometry, etc. Very important. So in a traumatized eye, one thing may be, especially if the cornea is involved, getting a keratometry may be extremely difficult. Second, our traditional way of measuring the axial length is by a contact or an immersion biometry, which may be difficult in a fresh trauma, but in a already sutured eye or in a closed globe injury, it may be fine, but not in a freshly sutured eye. So the factors affecting is one, like I told you, the axial length measurement and the keratometry and the estimated anterior chamber depth, because especially in a traumatized eye, it may be altered. And again, the type of trauma, is it a closed globe or an open globe injury? Closed globe, I think we can go ahead with immersion biometry or a contact biometry. And the timing post trauma, if it is immediate, you have a open globe injury, you're going to repair the eye and also do a cataract surgery. How we do the biometry is important. It may be most probably absolutely difficult unless it is a self-sealing wound. If it is a self-sealing wound, probably you can do an optical biometry because you are not touching the eye. But immersion biometry or contact biometry, even if it is a self-healing wound, we cannot do it. So in those cases, probably you will have to go for the measurements with the contralateral eye, the keratometry as far as the axial length. Now, all post-trauma repair, even if it is not immediate, you can always go ahead with immersion technology. And old trauma, absolutely fine, you can go ahead with any method. And the challenges which are faced, even if the wound is already repaired, if it is a corneal tear, it will be an irregular cornea. So you can try to get keratometry values from the same eye, but always compare it with the contralateral eye. And if the ipsilateral eye is very haphazard, then leave it and go ahead with the contralateral eye. This is the keratometry perspective. See, if you have a wound like this, and if you're going to repair this, you do cataract, obviously you cannot do any of this. You'll have to go for the contralateral eye. You cannot touch this eye. And yeah, like I told you, in a self-sealing wound, optical biometry may be possible. But you have to tell the patient that the chances of a residual error are quite high, and most of these patients, it may not be just the cornea or the lens which is involved. They may have multiple problems with the retina, etc. So many of them will not expect 6/6 vision, so it may be easier to explain. So you can use a ultrasonic biometry like this. Ideally, it is always nowadays contact biometry is almost obsolete because the applanation can cause the indentation can cause errors. So it's always better to use a Prager shell and go ahead with that, or the optical biometers. The optical biometer is definitely more accurate than the immersion. And the IOL selection, talking about the IOL selection, the type of material. See, you always, when you are dealing with a traumatic cataract, you should have a library of lenses. You should always have, because you don't know what you're dealing with. You don't know what is the state of the posterior capsule. You don't know how the rhexis is going to be. So you always should have hydrophobic 3-piece acrylic IOL, definitely. But you can always have a single piece IOL, because in a situation where you can place it in the bag, hydrophobic IOL is the best. You, depending on which technique you are familiar with, you can either have a scleral fix SF IOL or a glued IOL as a standby, or a posterior iris globe. Hydrophilic acrylic should be placed only in the bag. And the calculations, if you are placing it in the bag, then go for emmetropia, attempted emmetropia. If it is in the sulcus or scleral fixation, reduced by around 0.5 to 0.75, the calculated value. And if it is an iris globe, around 0.75 to 1. And just try that. Going through a few scenarios. this is a case in which there is a traumatic subluxation, as you can see. So you go ahead, you stain the capsule, and yeah, you do the rexes. Once you feel that, and if you feel that the bag is not stable, you can introduce your Sionis ring, and you don't suture the Sionis ring at that point in time. Okay, but make sure you just move it around and see that it is well placed inside the capsular bag, and then you can go ahead with a very slow motion phaco with minimum lateral separation, and you can go ahead and finish the surgery. Once you're through, then what you can do is you can implant the IOL, and after that what you can do is you can pass the suture through the Sionis segment. You can either do this in advance, the scleral pocket in advance, and then by railroading you can just guide uh, the suture through the eyelet, and you can fix the IOL. And this is another case where there is subluxation. It's better to use the iris hooks or the capsule hooks and support, then put the endocapsular ring and finish the case. And if then again you can fix the Sionis ring into the sclera, and that looks very well centered. Almost the same thing which is being done. And this is another case in which there is a this is a fresh case in which there is a self-sealing corneal tear. Actually, the phaco went on without any interruptions, but while doing irrigation aspiration, it started leaking. So first we repair the corneal tear, and then we go ahead with go ahead with the IOL implant. Here, this is an open anterior capsule, a pseudo-Argentinian flag sign because of the pre-existing trauma. Here, you just do try to remove as much of the because it's a soft cataract, traumatic soft cataract. Try to remove it using minimum phaco parameters, and then once you finish that, what you do is you just try and cut one edge of the capsular flap and make it into a hemirexis, and then you can go ahead and implant an IOL in the bag. It's always better to have a 3-piece IOL handy, because just in case something happens, you can always pull it up and bring it up into the sulcus and have an optic capture. And this is another case in which halfway through the procedure you suddenly realize that the posterior capsule is open. Actually, this patient had undergone intravitreal injection, and so you have to be careful. You have to take a thorough history. So this is an iatrogenic injury, iatrogenic trauma. So in this case, once you find that the posterior capsule is open, then you go ahead and try to remove as much. If you push in viscoat to plug the posterior capsule, never ever pull the phaco probe out. So that makes it the things even worse. So through the side port, inject viscoat, form the anterior chamber, and then go ahead with your maneuvers. And since it is not immediate, the rent is immediate, there will be some amount of fibrosis around the posterior capsular tear, so that you can always place the IOL either in the capsular, as this is where the rent is happening. Then you can either you have to do vitrectomy, then you put the lens in the sulcus, or you can do an optic capture. So yeah, this is the optic capture being done. And in case of an old trauma, this is a trauma which has happened and the cataract was removed, then you can go ahead and do a scleral fixation. I'm not because this technique is familiar to you, and iris claw also is a very good armamentarium tool in an armamentarium, because with minimal time and interference you can fix this IOL. The only prerequisite is there should be adequate amount of iris left. See, even if you have a sector iridectomy, you can still do a iris fixation, and you can do a pupilloplasty. So this technique, you should have a good instrument to hold, so that the hold is very important. Do not use a McPherson or any other instrument. Use a good lens holding forceps, and once you do that, you get the lens under the iris, and then using an iris hook or even a viscote cannula, you can just tuck the iris. Yeah, this is how the tucking is being done. Good hold, and then do the tucking, and then once both, you can, if the other haptic is above the iris, you can always leave it and regrasp, and if you're not sure, then always check whether it is behind the IOL or not. So again, you go back sidewise, and then tuck the iris into the claw. This is a posterior fixation of this thing. So always, since it is a large wound, you always have to suture. Iridectomy is not mandatory, but it is better in a traumatic eye. Okay, this is again a post-trauma subluxation of the bag IOL complex. For want of time, I'll just fast forward. So from both sides, you introduce Gore-Tex sutures, and you fix the IOL bag complex in situ. So you pass the suture, one above and one below the haptic on either side, and with this you get, once the procedure is over, you get you can have a Hoffman pocket, and you can tie it underneath, because the Gore-Tex sutures can be very irritating, and this is how it can be dealt with. So thank you. These are a few scenarios, and thank you very much for a patient here.
Thank you, sir. I think these were excellent videos, and we got an overview of how to deal with them. I have one question. So if there is a patient of trauma, acute trauma, it's a closed lobe injury, and the only finding we have is a cataract.
Yeah.
We do not know the status, whether it's subluxated or not. So do you think planning the IOL right in the beginning will be a good idea, or it's better to deal with the cataract, leave the patient aphakic, and then deal with the remaining, if there is, especially if there is iris inflammation that we're dealing with?
Yeah. So you mean to say it's a closed globe injury?
Closed globe injury, only inflamed eye. The surgery is traumatic,
and there is no anterior capsular rupture.
Yes,
There is no.
We do not know that the cataract is there. Only the lens is affected.
Yeah. If the anterior capsule is not damaged, I mean, that means this fluffy material is not going to come into the anterior chamber. If the anterior capsule is ruptured and you can see either particles inside the anterior chamber or the fluffy material coming out, then no matter how, you have to go ahead and do the surgery, because you cannot allow the patient to have a phacolytic this thing.
Right, sir.
So you have to remove it, and during the surgery you can evaluate and see whether the bag complex is stable. In that case, always be ready to implant. Anyway, you cannot get a good proper rhexis, so you'll have to go for a hemirhexis kind of thing. And since it is soft, it will come out. You can implant the IOL. But if the anterior capsule is intact, I would say it's always better to wait. Wait for the UVA to settle down.
No, so my question was actually like, during the surgery, you've planned the surgery, you're going ahead, during the surgery, because of the manipulation, sometimes the iris itself is inflamed, or there is some iris injury.
Okay.
So like in some cases where you're planning a iris claw lens, like, the bag is lost.
Okay.
So would you
okay.
prefer to place the iris claw in that setting itself, or would you wait
No.
to the iris to settle?
If there is if the iris is inflamed, then I would definitely wait. Okay, because
don't take
during the
up, yeah.
clawing, first of all, it's very difficult to gauge how, and definitely it will tear. And in those cases, you can see the claw anteriorly sometimes.
Right, so it
Because
might
of-
just tear up.
Yeah. So it's better to wait. If there is a lot of iris inflammation, definitely better to wait if it is a iris claw lens.
Right, sir. So I also have the same opinion that if you have a aphakia like this, or if there's a surgery has gone difficult, or a traumatic cataract, if you're planning a secondary IOL, it is better to wait for a month, let the inflammation completely settle. You can recheck your biometry also, decide on the lens, and then go ahead with a
Definitely
secondary
you can
IOL.
do that. Second, even if there is a mild amount of subluxation, it gets fibrosed. So it becomes much easier. Probably you can get away with just a
CTR.
CTR. You
Right.
don't need to fixate it. By around 1 month, it fibroses nicely in the corner.
Okay.
Sir,
Thank you
I
so much,
also
sir.
had one question.
Yeah.
Like in cases where there is a iatrogenic posterior capsule break because of anti-VEGF injection,
Yeah.
would you like to take up the cataract immediately, or you want to wait for some time?
If there is no emergency, like for example, if there is, because of the cataract is become mature immediately, you can definitely wait. Again, for the same reason, the injury and the rent will get fibrosed.
Yeah.
So most of the time it becomes easy. That fibrosed thing will just remain there, and we don't need to make any change. It's slow-mo phaco, and then using viscoat you can remove it, and you can put the IOL in the back.
Yeah.
Most of the
So
time.
what is sir saying? I feel that's also correct. If cataract is not very bad, it is not creating problem.
Yes.
You can wait for a month. By the time that tear edge of the posterior capsule will fibrose, and the chance of posterior dislocation of nuclear piece will be less.
Yes. Exactly.
Any other questions for sir? Okay, then I think we can take the next topic. Thank you so much, sir.
Thank you.
So next, I would like to invite Dr. Anubhav Goyal. He'll be talking to us about approach to the posterior segment trauma, understanding primary repair and secondary management.
So, first of all, I'll say thank you, Dr. Vanashree, for giving me this opportunity. So, my topic is on posterior segment trauma. So, most common important point in posterior segment trauma is meticulous closure of scleral wounds, which is very important for open globe injuries. As far as closed globe injuries are concerned, closed globe injury, if there is visible retinal break or an obvious retinal detachment, only those cases need to be operated immediately or intervened immediately for retinal breaks with retinal lasers. Otherwise, all cases with attached retina, you can conservatively treat and wait until the media get clears to intervene further for the posterior segment. So most tricky thing is when there's open globe injury, how to intervene, what to intervene, which test to be done prior and which test to be done later on. So I'll be dealing most commonly with open globes. So all these posterior segment traumas, basically zone 2 and zone 3, it can be occult or manifest. We have to see there can be presence of intraocular foreign body, or there can be presence of infection or endophthalmitis at the time you have seen the patient. So you have to very carefully see which zone is involvement and what is the present status. Foreign bodies in a very badly damaged eye with a lot of hemorrhage in AC and posterior segment, it's difficult to see. For that you need imaging. So goal is to restoration of integrity of the globe and avoidance of further injury to the underlying ocular tissues. So for very small scleral wounds where there is not much leakage, where there is a small wire, like a wire injury in the eye without much uveal prolapse, where you are seeing not much of tissue damage is there, you can just manage conservatively with antibiotic drops, and it will heal because of the tenon support. When you feel it's a bigger injury, whether it is occult or manifest, you have to, if it is manifest, you are very clear, you can take the patient. But if it is occult, the signs of occult skull rupture are when the eye is very hypotonous, when there is massive intraocular bleed, whether it's massive anti-chamber bleed or vitreous hemorrhage, massive subconjunctival hemorrhage where you are not able to see any the sclera, or massive lid edema which is obscuring and giving an eye very soft texture. So in this globe, exploration is mandatory. You cannot just leave the eye like this.
Globe exploration is mandatory, depending upon the appropriate anesthesia you are comfortable with. I prefer to operate these cases under general anesthesia, and special attention to be given to the areas of muscle insertion in these exploration, because these are the thinnest areas from where the globe perforation will be most expected. So the important pulse is the dissection of conjunctiva and tenons should be done from anterior to the posterior extent of the globe. Is a video showing you have to nicely open up tenons conjunctiva and explore whole maximum length of the tear, and after confirming the posterior most extent, if you start that time, it will be better. And the first suture will be which should be, if it is a limbal involving tear, first suture should be on the limbus. First suture should be taken on the limbus to maintain the anatomical integrity of the globe, and other sutures can be taken at the other lacerated most prominent anatomical landmarks, so to maintain the aligned anatomical integrity. For scleral sutures, that Dr. Sogaranjini told, 70 victuals are best. For corneal, anyway, she has told very nicely. So interrupted sutures are preferred sutures to be done in scleral perforations. This is a video showing how we have to take these interrupted sutures, first at the limbus and others at the sclera. So the suture should be the deep scleral bites, so that the maximum sclera can be taken without much underlying tissue exposure. You have to keep in mind to avoid damage to the underlying tissue, especially choroid, because if you engage choroid, your patient might land up into sympathetic ophthalmitis in the other eye later on. So tubular tissue and underlying tissue like vitreous and retina also be taken care of. So this is a diagrammatic presentation in which it is shown that the first of all limbus has to be sutured, and then along with that cornea, anterior segment, zone 1 and zone 2 has to be sutured. So after that limbal suture, the most prominent lacerated zones like this angle has to be sutured, so, and this second angle has to be sutured, so that the globe positioning will be better. Then further on you can give sutures in the intermediate areas. So the best thing is close as you go. First of all, suture in the anterior part, and those slowly expose the posterior part and go slowly to the posterior most extent and close on the go. If you are feeling a little bit difficulty in exposing, you leave a long suture end at the trailing suture, so that you can use that suture to pull the eye and expose the posterior part of the wound. So very important is, should not cut blindly whatever is exposed from the wound. It can be uvea, it can be retina. So if you examine the wound properly, if it is retina and uveal tissue, you have to reposit it. If you are seeing vitreous, you can remove it, cut it, and amputate and suture the wound. And if the muscles, if the wound is this is fourth pulse, if the wound is extending below the rectus muscles, you have to disinsert the rectus muscle to see carefully the extent of wound, and you have to reinsert them muscles later on. Okay, and if the wound is very posterior, you are not able to see the extreme posterior most extent, you can leave it, but then as far as possible try to expose the posterior most location and suture it as far as possible. Should not leave any open edge of the tear. So so this is internal. So it's very mandatory, if you're seeing any necrotic or infected tissue, you have to remove it nicely, so that the chances of post-op infection can be avoided, and intravitreal antibiotics can be given at the end of the surgery to avoid post-op infection. I prefer to give antibiotics in all the open globe injuries, especially posterior segment involving. If it is a very large scleral tear, if there is a tissue loss, you have to use a graft material. Best will be homologous scleral graft, patch graft. You can also use split thickness dermal graft. So and this is a video showing nice exposure of conjunctiva and tenons starting from anterior to posterior. Whole length has to be exposed, and you can start suturing close as you go technique from limbus to the posterior extent, and interrupted suture has to be given with a nice closure. Then muscle is disinserted to see the posterior extent, and nicely sutured all the tear wound, and then muscle is later on reinserted, checking the wound whether there is any leakage or not. After confirming the whole extent of the wound, only then you have to close the eye. Then only it will give a good integrity. Otherwise, it will end up into phthisis or other complications later on. So this, sorry. So in this here, I want to stress, if the eye is very badly traumatized and there is no view, you have to do primary closure as soon as possible. You should not wait for CT scan or B scan, because delaying delaying for the imaging might create more chances of infection. So that anyway, we are not going to intervene for any other thing in the primary surgery, and CT scan or B scan to confirm the retained intraocular foreign body can be done on the later rate. But if there is a good view, then obviously you have to image as soon as possible, so that in case you need to remove the foreign body, you can do it on the same surgery. So this is a case in which the view was clear. This is and there was a thick iron 6 mm iron metal piece injury in the eye, where you can see a scleral wound, entry wound, which here is exposed and initially sutured nicely. This was self-opposing wound, but I sutured it, and then 3 pars plana ports were made. I fastened the video. Vitrectomy started, and then see this foreign body is disengaged from the inferior part of the retina. Vitrectomy completed, and vitreous has to be removed from all edges nicely. You should not leave any vitreous at any edge. Then a big scleral entry opening has to be made, bigger than the foreign body size, so that it can be easily taken out. It should not fall back. It should not get engaged in the pars plana. This is a rounded edge foreign body, was difficult to take it out for forceps, so I take it out with magnet, and I opened the wound with a forceps so that it should not fall down. You see that I'm holding this wound and slowly taken out the foreign body. It should come out in toto without breaking into pieces. Scleral wound should be closed like a normal perforation and with interrupted sutures. And then later on there was a inflamed vessels which should be lasered. Then this is the retinal tear which was there, which was cryo treatment was done to prevent chances of retinal detachment in the future. This should be done. And then depending upon the tamponade you can prefer, I prefer to give oil in such cases because of chance of recurrence, retinal detachment in future. And also additionally I prefer to give cryo at the edges of scleral tear repair. So this is the main crux is intervene intervene as soon as possible in a posterior segment trauma to prevent infection chances postoperatively. Imaging can be delayed for next day to confirm intraocular foreign bodies, but if media clarity is good, you can intervene on the same day with the imaging.
Thank you so much, Dr. Anubhav. Any questions? Yes.
Yes, sir.
Earlier we used to say there is a golden period, like any uveal tissue which is prolapsed outside. If it is less than 4 to 6 hours, you can, reposit it. Otherwise, you have to abscise it. Does it still hold, or?
No, sir. Now we are not trying to excise it because its chances of hemorrhage and RDs are more. Now, unless we are seeing any infected tissue, we are not excising it. We are just repositing it. We should now reposit it. We should not excise it, and we have to close it. Anyway, now as a golden rule, we are giving intravitreal antibiotics with all the posterior segment trauma. So that is the second way to prevent the infections post-operatively.
Second, you said you can remove the vitreous. How do you do it with like normally with a Vexel sponge or something like that, or you use a vitrectomy cutter?
The vitrectomy cutter is best, sir, because it can precisely trim out the vitreous.
Yeah, and
but if you
doesn't pull.
It doesn't pull.
Yeah.
Otherwise, if you use the bird and your Vanas scissors, it will pull the vitreous. We should not pull any wound. Any tissue under deeper tissue should not be more pushed out from the wound. You have to close the wound. That's why all these open globe injury, if it is a large wound, prefer to operate under GA. Should not give local anesthesia. That is an additional thing I wish to say.
Thank you. That's a wonderful talk.
And also one question. So for simple, sometimes we have these very small scleral tears, not very large ones. But when we are doing the repair, the uveal tissue will just keep coming into the wound when we are taking the bites. So any tips that you can guide
Yeah.
the
So
answer to
in
this?
this wound, instead of taking from anterior lip, from the anterior lip to posterior lip, I will prefer to take first bite in the posterior lip and then second bite in the anterior lip, so that the knot will come in between the lips and it will also push the wound uveal tissue beneath.
Okay.
If you take the suture bite from anterior to posterior lip, it will, there are high chances that it will engage the uveal tissue and come out, and then needle will come out in the wound.
Okay. Okay. Thank you, sir.
Okay. Yeah.
In a posture segment injury, of course, it's a combination of anterior and posterior.
Yeah.
What is the time interval you are allowed for an anterior segment surgeon to?
Sir, it has to be intervened as a comprehensive approach. If it is anterior segment tear, also corneal surgeon has to operate, and posterior segment has to operate. If it is a lid tear, oculoplasty has to operate on the same time. It is not like posterior segment has to be done separately, anterior segment has to be done separately, oculoplasty will see next day. Everything has to be intervened as soon as possible.
There is no time increment for the
No, no. It's basically, I'm just dealing posterior segment. I showed this, but everything has to be dealt simultaneously.
So I had one question.
What systemic antibiotics do you use if the wound is bone deep in adults and in children?
Sir, I usually don't like to give systemic antibiotics until unless I am suspecting end of at that time. Even for end of, since you are giving intravitreal antibiotics, it's antibiotics acting in the area. So systemic antibiotics, even in endophthalmitis studies, there is not much role of systemic antibiotics. So I prefer, usually do not advise to give systemic antibiotics.
Usually the trauma is concomitant. You will have a bone deep wound on the other side. So that's why I started with the
If you are seeing, if you are suspecting adnexal injury, lid tear or soft tissue injury or chance of infection, you can give systemic antibiotics. But just for this posterior segment injuries, systemic antibiotics doesn't have much role as such, sir.
Yeah, I just differ. Like, I in all trauma, I prefer to give IV antibiotics because I mean, eventually some of those will go for phthisis, and the medical legal point of view, I think if you are safe, if you give systemic IV antibiotics, and I prefer to start with cefuroxime. I mean, the most common cause is GNP, gram negative bacilli. So cefuroxime, I mean cephalosporins primarily.
Yeah, you can.
Yeah. Then, like now, Dr. Soni has asked to know. Actually, I prefer to excise iris if it is more than 6 hours because ischemic iris can cause endophthalmitis, and this is very difficult to treat post-traumatic endophthalmitis rather than this thing. I mean, that's what I feel. I don't know what others are doing.
No, usually we are not,
Yeah.
now we are not excising.
I can one last question.
Yeah.
Both ulcer and myopathy. Sometimes in these trauma, we may not even be able to find the muscle sometimes. Even before we disinsert it, we don't know where the muscle has gone. So how do you approach such a case? Like if you have to go fishing for the muscle, it has already been.
No, I will prefer to take the two sutures on the two muscle ends carefully. You should not take one suture, and both sutures has to be kept carefully. If you have disinserted the muscle with two sutures exposing, there are very less chances that you will miss it. If already missed,
Yeah.
then you have to pray to God.
No, it's actually in fresh traumas. If you see a lost muscle, if you just follow the track of the muscle, it will be there. If it's a fresh trauma, if it is more than 6 hours or more than one day, then it is literally difficult.
It's
Have to do
edematous
a-
tissue and
yeah.
inflamed tissue. It's difficult to identify it.
Lost muscle is like.
Thank you, sir.
Thank you so much. Please come on the stage for a photograph.